Thank you. So good evening, everyone. And thank you for taking time on a Friday evening to join this event organized by Merck. It gives me immense pride to actually open the session. And before we get into the session, a brief background on the history of Merck. So this is a company which is more than 350 years old, and we operate in more than 66 countries globally. This company was founded in 1668. Next slide, please. So my name is Sudipto. I'm from the Medical Affairs Department of Merck India. And just to give you a brief background, Merck, as you all might know, is present in the healthcare business. But apart from that, Merck is also present in the life sciences business and in the electronics business. On the life science and electronics side, I think we have a wide array of offerings, and we deal with a wide array of client bases as well. Now, amongst them, I think notable in life sciences department, we are present in genome editing, so tools like CRISPR. We are also present in several ingredients and reagents that are actually provided for food and beverage industries. And at the same time, we play a significant role in terms of process solutions for biological.
Recording in progress.
For electronics, yes, of course, we are quite significantly present in the pigment space, in smart technologies, and of course, for future mobility. Coming to our healthcare space, I think our very own healthcare department. So in the healthcare space, apart from oncology, we are present in neurology and immunology disease, mainly in multiple sclerosis, but also for several other inflammatory diseases and autoimmune disorders. We're also present in the fertility business. In the fertility business, we have offerings around IVF stimulation and also bringing hope to creating new lives for infertile couples. In the cardiovascular metabolic space and endocrine, we have several drugs which actually are included in the management of hypertension, diabetes. At the same time, in the endocrine space, we have drugs which actually treat hypothyroidism and also growth disorders. Next slide, please. With that, we come into the oncology space in the healthcare business. So in oncology, of course, you might be knowing that we have three major brands. Bavencio is our own immune checkpoint inhibitor, which is actually approved in 3 indications, metastatic Merkel cell carcinoma and GU cancers. Tepmetko, which is present or which is approved in exon 14 skipped alterations in non-small cell lung cancer. And coming to our very own Erbitux, the core and the essence of the meeting today. So Erbitux has been in India for more than 20 years, and we are actually approved in 3 indications, 2 in head and neck cancers, and 1 which is of interest today in metastatic colorectal cancer space. Next slide, please. So this event is especially important and critical for all of us because we are celebrating the 20th anniversary of Erbitux. And over here, you'll be glad to know that till date, more than 740,000 patients have been treated worldwide with this drug. And in the colorectal cancer space alone, this might be close to around 450 to 500,000 patients. Next slide, please. So without further much ado, I would introduce the agenda for today. So we have an esteemed panel of speakers, faculty, and we have our international guest as well. So to begin with, I would first start with Dr. Amit Rauthan, sir. Next slide, please. So Dr. Amit Rauthan, sir, needs no major introduction to everyone. So Amit Rauthan, sir, is the HOD and consultant medical oncologist at Manipal Hospital, Bangalore. Sir has more than 2 decades of experience in the field of medical oncology and more than 20 international and national publications and scientific papers. He's also involved in several clinical trials, both as co-investigator as well as principal investigator. And of course, he's a guest speaker at several national and international forums. With that, I would invite Dr. Amit Rauthan, sir, to take on the session from here. Thank you.
Thank you, Sudipto. Thank you for this opportunity. Good evening, everyone. Will you share the slides or should I do it?
So I think the slides are on.
Okay, so you will change it.
Yes,
okay.
Yes.
Okay, great.
Thank you.
So let me just put it on full screen. Okay, right. So So what we're going to do is quickly, we're going to look at the current treatment guidelines in metastatic colorectal cancer. Next, please. We have seen how the space has changed so rapidly, metastatic colorectal cancer, the way we have adapted to the chemo regimes and then adapted to targeted therapies. And there have been a lot of shuffling in spaces. And so we have had guidelines which have kind of changing very rapidly. So we saw the ESMO Precision Medicine Working Group guidelines in July 22. Then we saw the ASCO guidelines, the Pan-Asia guidelines, and we have had kind of modifications happening very rapidly. Next, please. So what we'll do is we'll quickly look at the updates focusing on the ESPO Precision Medicine Working Group and consensus guidelines. And we'll focus on these key areas: the RAS wild type, the MSI high, the BRAF V600E, liquid biopsy, and also emerging markers. Next, please. So if you look at the recommendation for optimizing the treatment of the RAS wild type patients with metastatic colorectal cancer, next, please. We've had the next, please. So we have done as per the 2023 guidelines, now we are saying anti-EGFRs for the left-sided for the metastatic setting for all patients as first-line therapy. We say an anti-EGFR with doublet chemotherapy. It has a 1A recommendation. We also anti-EGFR is combination for conversion therapy, where complete resection is the aim. Again, there's a recommendation of 2A, but clearly anti-EGFRs have made a space there in the left-sided as first-line therapies in combination with doublets. In the right side, the RAS wild-type space, we still talk about chemotherapy with bevacizumab as a combination. The chemos could be doublets or triplets, depending on the clinical situation, patient fitness, and the scenario we are in. But there is still some data about the anti-EGFR agents plus doublet chemo, where a higher response is needed for conversion therapy, and this comes from the FIRE data, which is a category 2C recommendation. This is something which has a limited usage in our practice, the right-sided space, but the left-sided space, clearly anti-EGFRs are standard first-line therapies in combination with chemotherapy. Next, please. So also now anti-EGFR agents have been recommended as a maintenance in patients of those who receive oxaliplatin-based chemotherapies with anti-EGFR agents. Now, this is different from the 2018 ESMO Pan-Asia guidelines, which did not recommend anti-EGFR agents as maintenance. But now we have data which is based on the EPIC trial and the Panama trial. The EPIC looked at cetuximab irinotecan versus irinotecan alone, and then cetuximab was continued, and there they saw a better PFS when you continued cetuximab. And the Panama saw panitumumab with leucorin 5FU, and continuing the panitumumab leucorin 5FU had a better progression-free survival. So now anti-EGFR agents with fluoropyrimidines in non-progression patients can be used as a maintenance regime. And this is something that we do use in our patients, especially who are able to tolerate the drug without significant toxicity. Those who are doing well, we do continue cetuximab as a maintenance drug also. Next, please. Also, a very interesting change happening now in the EGFR space is the re-challenge of anti-EGFRs is what we are talking about. And we have seen now patients who were KRAS wild type, got anti-EGFR first line with chemotherapy. They progressed, and then we gave them a off period from anti-EGFRs, treated them with chemo with Bev, and then again re-challenged with anti-EGFR. If they are RAS wild type, if they are maintained, these are patients who are showing response to cetuximab again. And we have seen data coming up from these two trials. We saw the cricket trial giving cetuximab irinotecan, and there was a benefit if they were ctDNA negative for that they were RAS wild type by ctDNA, and they had a better PFS than patients who developed RAS mutation. Also, the CAVE study looked at cetuximab, evolumab, and it showed similar kind of a data. We also have the Chronos study there, which also looked at the same kind of a situation. So this is kind of a new learning happening that KRAS wild type patients treated with anti-EGFRs at progression after a window period of treating with some other therapy, if you do a cell-free tumor DNA and find it to be wild type, you can re-challenge with anti-EGFRs with some benefit. Also, there are new understandings happening. We are using terms like neo-RAS wild type, and that is a patient who is KRAS mutant is maybe at progression loses the KRAS mutation, and that's called a neo-RAS wild type on blood NGS, though this is something that we are all debating, does this happen in practice or not? But these are definitely new and exciting information coming out, and this is coming out because of better cell-free tumor DNA testing, and that's helping choose better in the relapse recurrent settings. Next, please. Also, recommendations for the MSI and the BRAF V600 mutant patients. Next, please. So we've seen the immunotherapy has become standard therapy. It started off with a second-line therapy for MSI high metastatic colorectal cancers, but now we saw the 2023 guideline recommendation. It as Pembro has become first line from the, we saw the data from the keynote 177, Pembro versus chemo, clear benefit in terms of progression-free survival, a very significant benefit. So Pembro has become standard of care, but I think what will happen is we will have to rewrite this guideline very quickly, because we've seen the EP-Nivo data coming out from the Checkmate study, which showed a huge benefit in comparison with chemo in the first-line setting. So I think very soon we'll have to rewrite the guideline saying Pembro could be one option as first-line therapy, or EP-Nivo could also be a first-line option for our MSI high patients. With the EP-Nivo study showed a much greater hazard even compared to Pembro in the first-line setting. So immunotherapy clearly has made a space in the MSI high metastatic colorectal cancer, moved from second line to a standard first line. I really don't see any patient where we should recommend chemotherapy as a first line setting for MSI high patients. So making a point of doing MSI testing for every patient, doing it MMR, IHC, simple to do, quick results, and choosing therapies with immunotherapy as a first line setting. Next, please. For the BRAF V600E mutation, again, we've seen the 2020 recommendation. It's come from the Beacon study. Beacon study was looking at encorafenib plus cetuximab. So you're targeting BRAF plus anti-EGFR versus standard of line chemo plus biologicals. And this was for second line patients, two or more lines of therapy, one or more line of therapy. So you're looking at second line and beyond patients. And here, what we saw, a clear significant benefit in overall survival, progression-free survival, and overall response rate when you use an encorafenib plus cetuximab treatment in combination. So BRAF V600E, second line setting, we are saying directly targeted approach is better than using the chemotherapy plus biological approach. Now, there are different learnings from the BRAF V600E. In colon cancer, what we are learning, the triplet may not be required. We do not read the BRAF and the MEK inhibition as we talk about in melanoma or in lung cancer, where we say BRAF MEK is important. Here, BRAF with anti-EGFR is enough, and that result showed this, Beacon study showed the same benefit of a doublet versus a triplet in that sense. And that's why the guidelines have clearly said encorafenib cetuximab. A BRAF plus anti-EGFR is good for this group of patients as second-line therapy. Next, please. What about targeting HER2 and KRAS G12C? These are other interesting biomarkers. Next. So in the anti-HER2 space, we have seen now the recommendations changing. The recommendations are for patients with third line and later lines of setting. But what has changed was a few years ago, we only had trastuzumab lapatinib as an approved regime, and that was in the late line setting. We also saw some data from trastuzumab pertuzumab study, but I think the latest Mountaineer study was looking at trastuzumab with tucatinib combination, and it really showed a significant benefit in this group of patients. So trastuzumab tucatinib, though it's not there in this guideline yet, is getting as a therapy which is showing very good responses and is getting an approved therapy into this space of HER2 positive settings. Of course, the other exciting drug, trastuzumab deruxtecan, which is now making space for every HER2 positive disease, is also very important and is come into the guidelines for treatment of patients with HER2 positive colorectal cancer. So an important thing to do in metastatic CRC is to look for HER2, and it's just a HER2 IHC testing. So HER2 amplification of HER2 overexpression by IHC is what we are looking for. It's not the HER2 mutation which we are looking in colorectal cancer. Next. Also, we have seen the recommendations come in for metastatic colorectal cancer with KRAS G12C mutations. A small percentage, KRAS is about 40% to 50% in colorectal cancers, metastatic colorectal cancers, but the KRAS G12C is a small population, but clearly we have seen data of that in colorectals. If KRAS is mutated, in KRAS G12C is present, treating with the KRAS G12C inhibitor plus an anti-EGFR inhibitor is the way forward. We have seen now data from the Crystal-1 study, cetuximab plus adagrasib showing a disease control rate of 85% and a duration of response for at least about 6 months. We also saw a code break study showing sotorasib also with similar data sets. But we're learning a single agent KRAS G12C in colorectal cancer may not be enough. It's the same way of having the feedback loop of getting the EGFR up. So as one of these drugs has to be combined with an anti-EGFR drug to get a deeper and a longer response in the KRAS G12C mutations. Next, please. Testing is now clearly recommended, and we always say we have tissue testing, but also liquid biopsies have become very prominent and dominant in these treatment options. Next, please. Next, please. And there are a lot of unmet needs in the APAC region. We feel a lot of challenges. We have issues where patients cannot access the local healthcare services. Medical services are available in various clusters, and everyone cannot get a uniform treatment. We have issues with availability of drugs. We have challenges with costs in our patients, and there is difficulty in adapting to guidelines because of various availability of cost of medications and their cost, and these are challenges we all face. Also, there are a lot of clarities which are required because of the new terminologies which are coming in, new spaces which are being created, especially the neo-RAS wild type kind of space where people still debate between is neo-RAS wild type a myth or a reality, and that's how we keep debating these new spaces which are coming into practice. Also, MRD testing with liquid biopsies, which type of platform for liquid biopsies, how deep are they going, how much we are able to test, these are also becoming very important and will have a role to play in future. Next, please. So I would like to summarize, we have completed, or we have changed the guidelines, and the guidelines will keep changing very rapidly because of the advances which are happening. And I think with this, we'll move forward and listen to the next talk. Next, please. So I think now we will listen from our international faculty, Professor Sebastian Stinzing. He's Professor of Medicine and Head of Department of Hematology, Oncology, and Tumor Immunology from Berlin, Germany. He finished his residency and specialized from hematology and oncology at the hospital at Ludwig Maximilians University of Munich. He's joined the research group of oncology, and in 2012, Professor received the prestigious Research Fellowship Award from the Deutsche Krebslife in Bonn, Germany. It will be a pleasure listening to Professor Sebastian, and over to you. Welcome, Professor.
Well, thank you so much for this very nice introduction. And first of all, I want to thank, of course, Merck for giving me the opportunity to talk to you about optimizing the outcomes with treatment sequencing in the RAS wild-type metastatic colorectal cancer area, the evolution of personalized treatment we have all witnessed during the last years. And I think you have really set the case for precision oncology and all the changes we see in the treatment of colorectal cancer now and also tomorrow. First of all, these are my conflicts of interest. And when we talk about using anti-EGFR antibody, of course, we have to talk about first-line treatment. We have to talk about maintenance in first-line treatment, on-off strategies, and also re-challenge. So let's start with first-line treatment. And I usually start with this kind of overall introduction. We have the first-line metastatic colorectal cancer treatment landscape. And as you all know, we have those principles, irinotecan and oxaliplatin doublets are usually seen as equally efficacious. RAS mutant and RAS wild-type right-sided may be treated with doublet plus bevacizumab, triplet in selected patients. RAS wild-type left-sided, especially in Germany, also in the European ESMO guidelines, we have a very strong recommendation, and we say that we should treat those with doublet plus anti-EGFR due to the overall survival benefit we have seen throughout many trials. And then, of course, you already touched on MSI high, ICI or ICI combinations. I think since we have seen the data, the preliminary data of the nivolumab ipilimumab combination, the 8WH study earlier this year, probably ICI combinations will be the way to treat those patients. And of course, we also have molecular pathology, and this has also developed rapidly over the last years. And it just happened that I looked up the ESMO guidelines of 2012, and there was no molecular pathology at all. Okay, this was before we had to look into KRAS exon 2 mutations. The big questions in those times, and this is just 12 years ago, was basically, should we start with irinotecan or oxaliplatin? Well, times have changed, and of course nowadays in my clinical practice I would test for the extended RAS mutations, so KRAS and NRAS, exon 2, 3, and 4 hotspot mutations. For the BRAF V600V mutant, of course, the MSI high, and also within the KRAS mutant population, I would also look for the KRAS G12C mutations, as we have the combination of anti-EGFR plus KRAS G12C inhibitors on our hands. When we talk about how to treat those patients, and we now want to really focus on those left-sided RAS wild-type population, and we have the data that we have produced already 12 years ago or 11 years ago, which is the FIRE3 data, where we basically looked into the question, should we treat our patients RAS wild-type in first line with either cetuximab or bevacizumab? It was a head-to-head comparison, a phase 3 study. And especially when we now look into the left-sided tumor population, after 3 years, half of the patients are still alive if you start with anti-EGFR, with FOLFIRI-cetuximab, versus 35.8%. So roughly 1/3 is still alive if you start with bevacizumab. This is strong data, and also with a long-term follow-up, you basically are able to almost double the 60-month survival rate from 10.5 months to 20.7 months. Also, the median survival benefit with more than half a year makes this data very clear. If you have a left-sided RAS wild-type tumor, please start the treatment with using anti-EGFR antibody, FOLFIRI-cetuximab, FOLFOX-cetuximab, or maybe also panitumumab. You all are aware of the Paradigm study. This is a study of our Japanese colleagues using FOLFOX as a backbone chemotherapy. Here they basically tailored the protocol according to the retrospective results we had from the FIRE3 study. So they looked A, into left-sided tumors, B, they also looked into overall survival as overall endpoint. And here, this is the only prospective phase 3 study, also proving the superiority of anti-EGFR treatment in comparison to bevacizumab in first-line treatment. The median overall survival, again, is not as prominent, around about 4 months. But also when you here again look into those data on the 5-year survival data, you have roughly 20% versus roughly 30%. So again, a gain of 10% of survival rate after 5 years. Well, this is basically the doublet for FOLFOX or FOLFIRI, but we also have data on the FOLFOX series. Here, the deeper trial, also done by our Japanese colleagues of Yuzo Nakawa, using FOLFOX series as backbone chemotherapy plus cetuximab. This can be quite toxic, so only experienced physicians should actually use this. And this was compared to FOLFOX series bevacizumab. They used a very new endpoint, the depth of response. So how far can we basically shrink the tumor down in size? And this was the median. This was the primary endpoint. And as you can see, it was positive. We all know that for FOXIRI plus cetuximab, or that the cetuximab has a more pronounced overall response rate. And here, when you take the median depth of response, so using the size of the tumor, you see here, it was quite significantly positive for the use of cetuximab over bevacizumab. So very clear data. And this is also here, this is the updated, this is the PFS data. As you can see also, there was a gain in progression-free survival for those patients. So whether you use FOLFOX, whether you use FOLFIRI or FOLFOXIRI, you have positive data showing that anti-EGFR treatment using cetuximab is getting you to a more pronounced response, and also to a significant longer overall survival. I think these are very important points, especially if we think about oligometastatic disease. If we want to shrink down the tumor, because then the surgeons have the possibility to resect the tumor in curative, or the metastasis in curative intent. I think this is important to know, that if you want to use anti-EGFR, you will get more depth of response. Well, of course, toxicity kicks in. So especially when you start with FOLFOX, we know that you have a problem with polyneuropathy, which usually occurs after 3 to 4 months of treatment. So maintenance was introduced quite early in those concepts, because in theory, we should use our treatment until progression or intolerable toxicity, and then you just stop, and then you go to a second line and then to a third line. But as we all know, treatment reality is different. We usually start with an induction treatment in first line for a limited amount of time, maybe for FOLFIRI cetuximab. Then you go back maybe to just FOLFIRI, just cetuximab maintenance. And then if you have a progression disease, you're still within the first line strategy. You just re-escalate, you add the chemotherapy back to the cetuximab combination. And when he's really on treatment and progressing on full chemo plus anti-EGFR treatment, then you have a real progression, and then you switch to second line. And of course, when you start with other options, you may go with FOLFIRI, then irinotecan cetuximab, then cetuximab, and then you re-escalate. So this is treatment reality. We have different patients with different toxicities. So we have to alter and we have to change treatment treatment administration. And I think our goal should be, if we start with a concept, with a strategy of anti-EGFR plus doublet, we should really try to prolong this time on first line treatment as long as possible by maintenance treatment, reuse of chemotherapy, reuse of anti-EGFR antibody as long as possible before we really switch to a second line to really get the most out of anti-EGFR treatment. Well, and of course, here we have also for the maintenance treatment, we have some recommendation in the ESMO guidelines. And why is this? Because here, if you look into adverse events, 3 months and 4 months, 6 months, you see the shorter the treatment with oxaliplatin, the better is the outcome. And the less neuropathy has the patient. And this is how they started early on the maintenance studies using FOLFOX bevacizumab, and then they really tried to reduce to no treatment, the green graph, bevacizumab alone maintenance treatment, and 5-FU plus bevacizumab. And these were those trials like the German maintenance study, but also the CAIGO-3 study, which were using FOLFOX bevacizumab first time, then get to a reduced maintenance treatment, and then tried to re-induct the primary tumor. And as you can see, well, yes, you're prolonging progression-free survival by adding maintenance treatment. It does not have an impact on overall survival, even though it was not powered. And as you can see, there's still a lot of events missing. But of course, if you start with cetuximab, how would you then do a maintenance study treatment? And the first data that was available was the MACRO-2 study. Here, 8 cycles of FOLFOX, so basically 4 months of FOLFOX cetuximab, and then they either did 5-FU, they went on with FOLFOX cetuximab, or they did single agent cetuximab, which was quite interesting. There was no difference in PFS. So after an induction treatment where you have remission or stable disease, you can switch to single agent, and you're not impacting single agent cetuximab maintenance. You're not impacting PFS, and you're not impacting overall survival, which is important. So less toxicity, the same overall survival, which I think is quite important. And this outcome of cetuximab maintenance is comparable to FOLFOX cetuximab after 8 cycles of induction treatment. The next study was the COIN-B study, doing a different approach, also the maintenance with single agent cetuximab, but really asking the question, what is the role of cetuximab here? And there was a treatment holiday if as the experimental arm here, and this was basically done until progression. And what could you see here? The intermittent cetuximab versus the continuous cetuximab, there was, from a statistical point of view, no difference. But as you can see, the continuation of cetuximab for both PFS and also OS had a strong trend towards longer survival times. So what can we learn out of this? Well, yeah, cetuximab maintenance show a trend towards longer survival when compared to drug holidays in patients that were treated with FOLFOX plus cetuximab for 6 cycles as an induction treatment. There are also more modern studies. The RMS study just presented at ESMO 2 years ago, which was doing 8 cycles of FOLFIRI. So we're not starting with FOLFOX, we're starting with FOLFIRI here, plus cetuximab. And basically the same what has been done in the MACRO-2 study, but just with a FOLFIRI backbone, single agent cetuximab as an maintenance treatment versus the continuous administration of FOLFIRI plus cetuximab. What is the outcome? Well, 8 cycles of 4 months. This is why only patients, of course, who have a progression-free survival of more than 4 months were basically randomized here. And as you can see here, the addition of FOLFIRI to cetuximab has a trend towards a longer survival probability in both the MITT, the ITT population, or the population according to the per protocol population. Using the ERMER study also, of course, have overall survival. Here you do not see a difference, but what is quite interesting here, the cetuximab single agent maintenance seems to be a little bit superior. So what can we learn? Whether it's you start with FOLFOX cetuximab or FOLFIRI cetuximab, the administration of cetuximab during the treatment maintenance phase is beneficial and is has a trend towards longer OS and longer progression-free survival. But of course, we have also data coming from FLOX, which is the Nordic way to give FOLFOX, I would say. And also here we have the same data, the single agent cetuximab as a maintenance. We have a good PFS of 8 months and also an overall survival of almost 2 years. Going to the other antibody, as you all know, we also have panitumumab on the market. There's also data on the EGFR maintenance using FOLFOX panitumumab, the Valentino study, basically showing that the combination of panitumumab plus 5-FU is better than panitumumab alone. Here, the PFS, which was the primary endpoint, was positive. The question, of course, is this the 5-FU or is this really panitumumab? So, the Panama study basically asks this question here: the maintenance is 5-FU versus the maintenance is 5-FU plus anti-EGFR. And here we have very clear data. As you can see, the combination of 5-FU plus EGFR is superior to 5-FU alone maintenance, and this is also have a trend towards a little bit longer survival. So anti-EGFR treatment, the continuation is quite important in first line to really have longer overall survival, to maintain the overall survival that we are gaining, which is around about 3 years in 3 years or 36 months of median overall survival, which we have seen in many trials. What was quite interesting, what is the difference if you go to the maintenance treatment? And here they measured actually within the maintenance treatment, the tumor response. And what was quite important after those 4 months of induction treatment, even after that, you see the combination of 5-FU plus anti-EGFR has a higher overall response rate during the maintenance phase with 40.8% versus 26% in the 5-FU only arm. So you see, you get to deeper responses if you continue anti-EGFR in the maintenance treatment, and this translates then into a longer median overall survival. The next question we were asking was, okay, what about switch maintenance? Should we really go on with FOLFIRI-cetuximab until progression, or would it be useful to switch from FOLFIRI-cetuximab after an induction treatment of up to 6 months to a 5-FU bevacizumab containing regimen? Is this possible, yes or no? And we were able to show this data in 2022 at ASCO, and here when it comes to progression-free survival, there was no real difference. Overall survival, quite unmature data that we were able to show. We saw here a PFS of more than 10 months, or almost 11 months, versus and an overall survival of more than 30 months, which we were aiming for. So you can do this, but what was interesting, because we were all afraid of secondary resistant mechanisms that may occur during first-line treatment if you prolong the time on treatment, and this did not happen. You see, there's no secondary resistant mechanisms that kicks in, so switch maintenance is not necessary. The next, of course, is the question, can we do an on-off strategy? And so can we basically show that after an induction treatment, which has been successful, can we then just go on a treatment holiday and go back as soon as there's progression? And how will this impact overall survival? And of course, quality of life, because many patients are quite happy after 3 to 4 months of treatment to get a time off chemotherapy for like 2 to 3 months. The first study that has actually was looking into this was the IMPROVE study of Avalone, which has been presented 2 years ago at ASCO. And here it was FOLFIRI-panitumumab versus FOLFIRI-panitumumab. And then after 8 cycles of 4 months, there was a treatment-free interval. And if they had progression during this treatment-free interval, they were just reintroduced with FOLFIRI-panitumumab. What is the data? Well, first of all, it is quite interesting. This is the progression-free survival. On treatment progression-free survival, as you can see, this is the standard treatment, which was has a quite long progression-free survival of 13.2 months. So it's a small study with 70 patients per arm, but again, 13 months I think is quite impressive. FOLFIRI-panitumumab intermittent, 17 months of median progression-free survival, so quite long. So the first-line strategy consisting of FOLFIRI plus anti-EGFR was good enough for 17 months, 1.5 years. I think that's quite interesting. And also when you here look into those 24 months, there was basically still 40 to 50% still on treatment with the intermittent versus no patients was on treatment in the continuation arm. So yes, we can prolong first-line treatment by adding pauses. This is a phase 2 study, only 70 patients, so this needs prospective validation in a larger trial. And of course, as you know, especially the left-sided patients really benefit from this strategy with an on and off. The next question, of course, is what about second line? How would be what is the best sequence for our patient? And I think this French study of Chibaudel really looked into the question, our standard of treatment. This is my standard of treatment for patients with left-sided RAS wild-type tumors, starting with FOLFIRI-cetuximab, at the time of with on and off, with maintenance. And then we have FOLFOX bevacizumab as a second-line treatment. The question is, isn't it better to start with bevacizumab with an oxaliplatin stop and go, so we have less toxicity, which deriving from oxaliplatin. Then after this, we go to FOLFIRI bevacizumab, basically bevacizumab beyond progression. And then we would use anti-EGFR only in the later line setting. Well, and this is also why we have set the recommendation in the ESMO guidelines and also in the national German guidelines quite clearly. It was the combination of 3 treatment lines, basically, where it's not as effective as 2 treatment lines. So the standard is basically here, as you can see, FOLFIRI cetuximab followed by FOLFOX bevacizumab as second line. A nice median overall survival of more than 36 months, so more than 3 years in median. And so again, here, this is clear that you may want to start with that you should start with anti-EGFR. It was quite interesting because what was seen here during the induction treatment, the response rate went up to 82.4%, so a strong tumor shrinkage, so really reducing the tumor burden for the patient, and this prolongs this that then have a longer progression-free and especially overall survival. 70% for FOLFOX bev is quite good. It's a RAS BRAF wild type population. Okay, this is very good data for this combination. And then also when you think about second line, here you can see 21% of tumor response, which is again higher than the FOLFIRI bev in second line. But this was not statistically significant. So if you want to induce tumor response, and this is the best way for me to really have the tumor control, I think it's very clear, the data, that we should start with FOLFIRI cetuximab followed by FOLFOX bevacizumab, because this led to higher response rate and had a trend for a better overall survival with a median exceeding 3 years. And this is what we want for most of our patients. Talking about re-challenge, and there was also some data on re-challenge there earlier today, but re-challenge is important because if you have a very active treatment in first line and you have used it with on and off, and maybe then you have like a progression-free survival of 17 months. The question, of course, is if you have a second line treatment and you failed second line treatment, couldn't we reuse the active strategy that we had before, re-challenge the treatment with anti-EGFR? The cricket trial, which was basically not a trial, it was a registry, because patients were basically included back here. They needed to have some kind of cetuximab-containing first-line treatment, which should be administered for more than 6 months. Then some kind of second-line treatment. Then they were able to enter this trial, which was a single trial, and then they did the treatment according to the BOND study using irinotecan and cetuximab in third line, reusing cetuximab in third line. The median overall survival was quite long, with, as you can see, 12.5 months for the RAS wild type population. 12 months for a third line treatment is really remarkable. Of course, we are talking about the small numbers, 25 patients here in total. But what was important, which really drives our way we treat our patients today, they did a baseline liquid biopsy RAS mutational analysis, and of course only those who really were RAS wild type at the re-challenge point had a benefit exceeding more than 10 months in this setting. And of course, when we talk about re-challenge, we think about also the Chronos study, which then introduced ctDNA measurements before panitumumab single agent re-challenge. And again, the data is quite the same survival probability, PFS of 16.4 weeks, which is 4 months, which is quite long for this later line setting. We also had some responses which were very nice. I'm not aware of overall survival data on the Chronos study so far, but you see, this is just working. And we are now trying to validate this data using the ongoing FIRE4 trial. Well, it's not ongoing, we are done with recruitment, but we are still waiting for overall survival events back here. We had a ctDNA measurements before randomization 2, and then they were basically the reuse or the re-challenge with irinotecan or FOLFIRI-cetuximab according to the hematotoxicity versus physician's choice, which was no anti-EGFR containing substances. I hope to have this data available at next ASCO. We think that we should reach the event rate for overall survival back here, probably by the end of this year. So how do we treat patients with a RAS wild-type tumor today? Well, in first line, of course, when we have a RAS wild-type tumor, tumor location is important. If you have left-sided tumors, it's quite clear. If you have right-sided tumors, we may or may not want to discuss later on whether we, in patients where we need response, we may also use anti-EGFR treatment. And then, of course, if you start anti-EGFR treatment, you then go to some kind of maintenance, which may be 5FU anti-EGFR. If you have progression during this, you're going back to FOLFIRI or FOLFOX anti-EGFR and the re-escalation. When you have then progression during treatment, you would go to an anti-EGFR free treatment, for example, FOLFOX bevacizumab, and then you go to third line. You should do a RAS wild-type liquid biopsy before, and you should have response to first-line treatment, and then you can re-challenge anti-EGFR in third line. And as I said before, and we were talking about those two antibodies, I just have 3 slides, how we may or may not want to choose between the anti-EGFR antibodies available, especially panitumumab and cetuximab. First of all, they are not the same. They have different binding sites, as you can see here. What is important for me, and which in my opinion also drives a little bit the toxicity, especially skin toxicity and hypomagnesemia, is here the receptor binding. Panitumumab is ×8 versus the epithelial growth factor, whereas cetuximab is only ×2 versus EGF on the EGFR receptor. So this, I have a feeling that some of my patients really have more skin toxicity and more severe skin toxicity. This may be one of the reasons. And then, of course, especially when we think about the data we have so far, we have, of course, a higher level of evidence for cetuximab, where we have large studies starting with the CRISPR, going to FIRE, and the SWOG, the CLHB-80405 or Alliance study that had been published in parallel, basically. And then the Chinese Taylor study, which also showed that this is an important first-line treatment. For the panitumumab, we have PRIME, and we have some patients also from Paradigm that may add on. So we have more data available when we want to choose the antibody. And then, of course, when we think about, is there additional actions next to the EGFR receptor blockage? Well, as cetuximab is an IgG2 antibody, we have the possibility that actually cetuximab induces antibody-derived cytotoxicity, which will then trigger an immune cascade, which will also, in the end, is cytotoxic for the tumor cells. To sum it up, for left-sided RAS wild-type metastatic colorectal cancer patients, doublet chemotherapy, FOLFOX or FOLFIRI plus anti-EGFR antibodies, cetuximab or panitumumab should be used to provide maximal treatment efficacy and superior overall survival to the patients. Anti-EGFR maintenance is feasible and efficacious. Re-challenge with anti-EGFR has shown promising results and is tested in a randomized study right now. And to prevent anti-EGFR resistance, on-off strategies have proven a long first-line PFS on treatment. Thank you so much for your attention, and I'm looking forward to our discussion.
Excellent. Thank you. Thank you, Professor, for the great insights. And I guess that that sets the stage perfectly for the next session. So I think we've heard a lot about the global clinical trials, the global evidence that goes behind building of the major guidelines and standard of care. With that, I'll introduce our next session. So respected Dr. Shyam Agarwal, sir. Chairman and Head of Department of Medical Oncology at Sir Gangaram Hospital, Delhi. Of course, I think for every one of us, Sir needs no introduction. For more than 3 decades of medical oncology practice, and Sir has been involved in several research papers and clinical trials. Sir has always been on the forefront for personalized care and tailor-made therapy. And Sir is also awarded the prestigious International Fogarty Fellowship for training in the field of bone marrow transplant and basic medical research at UCLA, Los Angeles. With that, I would welcome Sir. Sir, invite you to take on the session from here. Thank you.
Right. So thank you very much, Sudipto. And thanks to Professor for giving us a very enlightening talk on how to manage RAS wild type colorectal cancer. So I think the next is going to be an interactive session. I'm sure there are going to be a lot of questions for Professor and the panelists whom we have. I think, on the next slide. Right. So I think we do have the professor continuing and Dr. Amit Roth also there in the panel. We have Dr. Krishna Prasad, who is the Chief Medical Oncologist at the Mangalore Institute of Oncology, Mangaluru. Dr. K.M. Parthasarthi is the Senior Medical Oncologist at Dharamshila Cancer Hospital, Delhi. Dr. Nilesh Lokeshwar is Senior Consultant at Leelavati Hospital and Research Center in Mumbai. Dr. Sachin Gupta joins us from Max Super Specialty Hospital in Mohali. And Dr. Shashank Shekhar Das is at HCG Center in Kolkata. So I think, as has been pointed out, that we have moved really into personalized era for treating patients with advanced or metastatic colorectal cancer. And this slide, again, shows you the same thing which was shown earlier. We're talking about RAS wild type, then you have to have EGFR inhibition to the forefront, and the maintenance was discussed eloquently by Professor. We do have these subsets now where there is role of these newer agents such as MSI high. We use immune checkpoint inhibitors, whereas for BRAF mutants we have encorafenib and cetuximab. So I think let's move on to the next slide. I thought we should have a case where it becomes a little more meaningful for the discussion to take place. But I think this slide shows us the guideline for left-sided RAS wild type, where a doublet chemotherapy is used along with EGFR, and it's category 1A. And for conversion therapy, the anti-EGFR agent is, here the category 2A. So the question to the panel is, do you, use EGFR agent in the RAS wild type setting, and which one, cetuximab or panitumumab? So I think, can we open the discussion and ask maybe Dr. Sachin if he's there?
So yeah, I'm there. Good evening, sir.
So do you, have a preference? I think this question has been put here for any particular protocol in terms of chemotherapy, in terms of the choice of anti-EGFR inhibition, or you would, use them irrespective?
So, sir, both FOLFOX as well as FOLFIRI are equally good to be used in first-line metastatic setting. But since I am using FOLFOX as adjuvant, so it becomes a natural choice. We are more used to, using FOLFOX in our patients. But if we have some issue with, like, let's say a patient is diabetic, having neuropathy and all, I want to avoid oxaliplatin due to some reason, then I would choose FOLFIRI as my first choice. But most of the times I'm using FOLFOX, although both are equally good. And regarding anti-EGFR, since cetuximab came earlier than panitumumab to us, and we have more data available and more experience of using cetuximab. And so most of the times I'm choosing cetuximab as anti-EGFR.
Right. So basically, what you're saying is that the patient profile helps you taking a decision whether we are using oxali or irinotecan in the first line, and mostly it is doublet.
Yep.
Yeah, right. Nilesh, you have any different thoughts in terms of chemo?
So overall, I agree with what Dr. Sachin has said. I have another thought in the sense that I do feel that the choice between Folfox and Folfree is more based on the patient profile. In elderly patients, I prefer to avoid Folfree, and in patients who are diabetics with neuropathy, I prefer to avoid Folfox-based therapy. And with regards to the choice between the two anti-EGFR drugs, cetuximab is my preferred choice. I have a little concern with panitumumab-related increased rash as well as the electrolyte disturbances. And there was some data which suggested that probably as a doublet combination with cetuximab, Folfree is better than Folfox. But I understand that that is not conventionally followed. But yes, that's my take on this.
Great. So thank you for adding a few pertinent points here in your, in your speech. Anybody wants to make a point, Krishna or Dr. Amit, before we go? Yeah.
Good evening, sir. So I think one of the reasons we select Folfox probably is also the fact that no hair loss. And I think that's a pretty important point for somebody who goes through a treatment which is non-curative in nature. Patients don't look like patients, whereas once we start irinotecan, they look like patients. So I think that is also one of the important points in selecting Folfox, apart from the fact that, like Sachin said, we are all used to Folfox more than Folfiri, and we are pretty comfortable with that.
Okay. So Professor Sebastian, so the question is that, the similar kind of practice which we or you follow in Berlin?
No, absolutely. I think which is quite more important, how long are you going to treat those patients? 2 months, 3 months, who's going to go on to 4 months? I think this is some question that is quite important because at some point our surgeon would not be so happy about, fatty liver disease or blue liver disease, depending whether you start with irinotecan and oxaliplatin. So yes, when I have a patient which already have a fatty liver disease because of obesity, because of type 2 diabetes, I would rather start with Folfox in combination with cetuximab. If it's a patient that is quite younger, the Folfiri is fine. It's only for induction treatment, so hair loss is there, yes. It's not total alopecia usually, but if you just think about a patient that will be in curative intent, I rather start with Folfiri. The hair will grow back, and then I would go for the additive treatment after secondary resective of metastatic disease. I would then go to Folfox. So I have less Folfox toxicity prior to the surgery. I will spare this for the adjuvant treatment after surgery, usually to go with Folfox. Cetuximab and panitumumab are both efficacious. I personally have more experience with cetuximab because of all our trials that we have conducted. So I think it does make sense to apply cetuximab, and also until 2 to 3 weeks prior to surgery, we would go on with the cetuximab because wound healing is not as much as a problem, and also not bleeding during surgery as we usually see like with a bevacizumab combination. Right. So we are quite not so restrictive, and also we usually pre-treat all metastatic disease before we resect it, even though it's only 2 or 3 liver metastases that may be resected easily. We usually do 2 months of treatment before, just to see that this is really these are all the only metastases we have before we send those patients to surgery.
So let me just clarify, and if I heard you right, so in a younger patient, where you're looking for some kind of conversion or downstaging, you're going to start with FOLFIRI with cetuximab, and after you've done 2 or 3 cycles, and when then you've done surgery and you get R0, you switch to FOLFOX
Yes.
as adjuvant, right?
Yeah.
Okay, so I think any comments, Amit, on this strategy? If you start with FOLFIRI and then after surgery you switch to FOLFOX maintenance, or you continue with FOLFIRI? I mean, that is my, Amit, are you there?
Yeah. Yes, sir. So yeah, it's not something we are doing in our practice, but there is some modification to that. So we went through an era where we used for conversion a lot of triplet therapy. So we used to give FOLFOXIRI plus cetuximab for selected patients, young fit patients whom we wanted resection, and then after surgery we used to go with either FOLFOX or FOLFIRI. So there was some sort of a switch kind of thing happening there. But again, my question is, sir, is triplets completely out? We still do it for our young fit patients where we want to reduce it.
I think that's a very nice question. Yes, we did the same. So after we had this very positive data on conversion, also the different trials that show that triplet really have a remarkable response rate, but quite some toxicity. But nowadays, I would say triplet in first line is really, for me, most of the time limited to a patient population, right-sided tumors with RAS mutations, where they use FOLFOXIRI plus BEV to induction treatment. Anti-EGFR plus triplet, I rarely use this because I think cetuximab or anti-EGFR antibodies for itself are cytotoxic, and you have then 2 other cytotoxic regimens. And also when we think about what are we going to do in second and further line, you have limited options. So I usually do not use FOLFOXIRI for the RAS wild type population.
Okay, so thank you. I think we'll have more discussion on this aspect in the subsequent slides. The next slide, please. I think, yeah, right. So I think this is what, we thought we'll have a case here, which is going to raise some controversy because we are talking about right side RAS wild type metastatic CRC. And of course, the patient is symptomatic. And let's say that this patient is not 68 years, but say young patient, 28 years. And, yeah, right. I mean, let's make him a fit person rather than, then the choices would be, more if you have a fit and a young patient than as compared to an elderly. So, but what you see on the scan is, multiple hepatic metastasis with peritoneal carcinomatosis, which is not like florid, but then, you can see it on the PET CT scan. And it's RAS and BRAF wild type and MSS HER2 negative. And patient's, general condition is good, performance status is good. So, Dr. Krishna, the question is, I mean, what is the intent of treatment in a patient who has bilobar disease and who has, 5 lesions seen on the PET CT scan in the omentum? So, is it palliative, or are we looking at some kind of curative potential?
So, sir, in the presence of peritoneal carcinomatosis with liver lesions, I think we would err more in terms of palliative. But now that you have brought down the age to 28,
yes,
I think we would probably try conversion therapy in this patient and maybe reassess after 4 cycles to 6 cycles and then take it forward.
Right. So the issue is, what backbone of chemo and the partner, targeted drug?
Yes. So I think the recommendations keep changing here. And I think in the ESMO guidelines, this is one area where cetuximab with chemotherapy is recommended. And I think over a period of time, it has now become a doublet. So maybe FOLFOX or FOLFIRI with cetuximab.
So a doublet with cetuximab on the right side, RAS wild type, when you're talking about conversion.
Yes.
So which means that you're not talking about palliation. You're talking about some kind of a deeper and
Yes, yes. Considering he's 28 years of age,
so
I
we
think
get it. We get it. Right. So I think Dr. Sashanka Shekhar Das has not spoken. So
Yes, sir. Yes, sir.
Dr. Das, what do you think? Is going to be your approach? Dr. Amit raised the issue of three drug combination, and then of course the issue of right side. So, what is your present thought process?
Sir, firstly, based on the age of 28 years, means if the patient would have been elderly, this patient would have gone for pure palliation with some doublet plus
So
bevacizumab.
I think these days 68 is also not elderly, and once you are touching 80 plus, only then you are, I think, labeled as elderly to my mind. So let's not put 68 or 65 as elderly today.
Yes. So, yeah, as you were told, 28 years with right-sided RAS wild type. Sir, I would be my preferred approach will be FOLFIRINOX plus cetuximab in this case, triplet plus cetuximab.
Okay, so we have two votes here for cetuximab, one for FOLFIRINOX and one for a doublet. Dr. Parthasarathi, you haven't spoken. Your thoughts on this case? Would it be palliation or would it be conversion?
If there are no peritoneous carcinomatosis, I would have gone for a
There are
triplet.
five lesions which we are seeing there on the omentum.
Yeah. If patient is 20 plus and ECOG 0 and 1, I'll use a triplet FOLFOX3 with the BEV. Then continue with the 5FU BEV maintenance.
Okay, on the right side, KRAS wild type, you'll use FOLFOX3 and BEV for a young person.
Yes.
Okay. Yeah. Go ahead. Anything?
Yeah, if it is even if it is BRAF wild type also, if it is a BRAF mutation, then definitely you can use a triplet with BEV.
Right. No, that's we're saying it's BRAF wild type. Yeah, both. So Sachin, your thoughts?
Yeah, so to my mind, this patient is not operable and not a candidate for very aggressive therapies. So doing bilobar liver metastasis with peritoneal disease, I don't think is going to be a curative approach for this patient. So if a younger patient, so triplet with BEV could be a good combination for getting a better PFS and leading to a better.
For palliation, then why do you want to give triplet? Why not doublet and BEV or whatever?
Maybe he's a young and tolerate, we can have a better thing, but otherwise a doublet with BEV is good enough.
Okay, so you are okay with BEV. You're okay with BEV and a doublet for a young patient. Nilesh?
So in my mind, based on the scan and images seen, this doesn't look to be something that's going to come up for a resection very early. Of course, this is where it's very important to involve a multidisciplinary team where you have opinions from the radiologists, surgeons,
and the give chemo first.
I'm sorry, sir?
They're going to say give chemo first. So
no, I think that decision about whether it is going to be a conversion therapy versus a palliative therapy is very important. If it's conversion, I'd probably go with 3 drugs and cetuximab or 2 drugs and cetuximab. But if it's palliative, then my plan would be to sequence therapy in such a way that I have something down the line also. And therein, I would probably use FOLFOX with bevacizumab in the first line and keep irinotecan with or without a cetuximab combination for a later line.
Theoretically, maybe, let me put it this way, that if you have a patient like this, if you're looking at significant downstaging in the liver disease, you may be able to resect out some portion and give some, microwave ablation to the liver. And for the mental disease, you may come up with some kind of an aggressive treatment in the form of radical surgery and HIPEC. So, he's a 28-year-old male. So should that not be kept? Amit, what do you think before I go to Professor Sebastian?
Yes, sir. So these days I'm kind of very wary to say palliative for such patients because there's so much more access to various things. So liver-directed therapies have become more and more better, and integration, as you mentioned, sir, resection with some microwave ablation and some combinations. Nowadays, more and more patients ask about hepatic artery infusions. It becomes very complicated. And also our surgeons is telling us, oh, forget the small peritoneal disease. When we operate, we'll do HIPEC. So integration of various therapies is making it very complicated. And after this year's TransMed study, I'm afraid to say anything because they're saying they will transplant patients. And
Yes.
those patients with liver limited who have control with liver transplants are surviving for many, many years. So I think apart from that, but sir, we kind of, whenever we want a reduction in right side, I am much more of a favor of a triplet in many situations because I don't know how much they will respond. So if my patient can tolerate a triplet for right side, I prefer a triplet. I still use bevacizumab as my data. I understand that early tumor response data from FIRE3, but that's the only data set we have. I'm a little bit reluctant going for an anti-EGFR for the right sides because all the other data sets are not very clear on that. So there is a recommendation, but we still use bevacizumab plus chemo. Yes, if my patients are fit and fine and I want maximum reduction, it's triplet plus chemo, triplet plus bev. Otherwise, it's a doublet plus bev.
Okay, great. So you put your vote for bev for a right-sided, wild type, a KRAS wild type. So let's come to the professor. Professor Sebastian, you heard the Indian medical oncologists from all across the country, where you saw them, using doublet, triplet, palliative approach, a very, conversion and maybe a potentially curative kind of approach where you can look at liver-directed therapies, you can look at HIPEC and so on, and including liver transplants. So, I mean, what is the practice there in Berlin and in Europe?
So the question, of course, is we never know what's going to happen, right? So we would choose the most active treatment for this right-sided colorectal cancer. And of course, we would probably go nowadays with the Cairo 5 study using triplet plus bev. And, if it's a good responder, you may or may not have the chance to resect. This is with the young patients, right? Is it 20-year-old male, let's say 20-year-old female with 3 kids, these are things where we then try to do everything to keep them alive. Of course, the usual patient, which is 72, 75 years of age, you would rather go with a doublet. And with the doublet, I'm probably also trying to use anti-EGFR because we want to have, because you have symptoms, so we want to have response. HER2 negative, BRAF wild type, so we're doing some kind of selection here, not hyper selection, but we are doing the most important step with RAS, BRAF, and HER2 for those right-sided tumors, and also the occurrence of metastasis. I would say probably this is an anti-EGFR responding person, but all the options that were set are of course correct, and you never know what's happening. And of course, peritoneal disease is always a problem that is not solvable for many of our patients. Even the chemotherapy is fine, you are stick with peritoneal masses at some point. So as I said, a younger patient, I would probably go with FOLFOXIRI-BEV, older patient doublet plus anti-EGFR due to the molecular makeup.
Right. So you showed us the data from the deeper study from Japan, where FOLFOXIRI is combined with cetuximab. So you are not a proponent of that study. It's basically the side effects.
Well, it's quite toxic, So of course we may want to discuss this, but I would rather then look into more selected patient.
Yeah, right. So we need to be selective. So I think all of us have our own thought process, but I think the message. Yeah. Anybody wants to ask a question here?
Just wanted to ask from like everybody on the panel, does anybody have any such patient on follow-ups? Maybe a younger patient like this who would have benefited with the like neoadjuvant and followed by HIPEC, resections, liver-directed therapies, and a good benefit or good survival out of it or cure?
Yeah, I have a
Any
patient.
single
I have a patient who's now going on for almost 5 years after having HIPEC being done 3 years ago. And I pushed that patient for HIPEC because of peritoneal disease. And the patient is currently on maintenance therapy with 5-FU and I think BEV now. So I think we do have patients who are doing well post HIPEC for many, many years. I'm sure anybody wants to share any experience is most welcome.
Yeah, so Amit here, sir. Yeah, so our center was very dominant in HIPEC space for
Right.
many malignancies, and we have a good number of colorectal patients with metastasis whom we have done HIPEC, and they're going on for many, many years. So we do have that, and integrating even liver-based therapies, it's happening more and more. So that's why we are more and more reluctant to tell patients on the first day they are palliative. We just can't say that, sir. So we always say, treat them, let's see response in 3 months, and then we take a decision where we are going.
Absolutely, absolutely. Today only I saw a patient who had multiple liver mets and peritoneal mets, but then, I mean, the downstaging has happened, but patient is not still, suitable for a surgical approach. But then, we were reviewing their PET scans and their CT scans to see is resection a feasibility, because we need to have that in back of our mind that resection of the disease gives you, to my mind, added advantage. Maybe to an individual, but you never know who that individual is. So unless you do that, you won't, get to know. Professor, your thoughts on HIPEC for, peritoneal?
Yeah. I've one patient that was a young lady I treated 15 years ago, basically 16 years ago, and she had liver disease. So we did a resection. She got into peritoneal disease. Then she recurred. We re-surgery there, so she had problems also again with the peritoneal disease. Then she had 2 liver metastases, so we went on, and then all of a sudden she disappeared. And just at the end of my time in Munich, she came to my office. She was still alive, and she was asking me, should I still go on with a CT scan every 3 months? And I was just looking at her, why haven't you been here? Well, I couldn't stand the hospital anymore. Okay. And after also surgeries. And so, yes, we have those patients that are lucky patients, and also the biology of the tumor of the RAS wild type, BRAF wild type, of course, she was lucky, but we see those patients again and again. I totally agree to you.
So Krishna, Nilesh, any comments from your side?
Can I make a comment? So I think all of us have got patients who presented similarly. But at the same time, I think it's very important to initially stage the disease, and the liver extent of involvement is extremely important. I would take that initial assessment with an MTT very, very seriously, because otherwise you end up with a lot of toxicity and you end up losing many of the options that you can use in a sequential way. So when you say that in a patient like this, it's possible that out of 10, 3 or 4 would probably go for a surgery, or maybe even less than that. And therefore, I think the initial assessment is very, very important. And classifying, I mean, I'm not saying that everybody should be said palliative or not, but I think beyond a reasonable doubt, we can identify patients who will not end up in conversion therapy, and we can spare those patients from toxicity.
Great. Krishna?
I agree with Nilesh, sir. I think sometimes it is extremely difficult. So if this patient is 68, probably we would not be very aggressive. And we never know. He might be one of those very good responders, but I'm not sure we will not start such patients on very aggressive treatment. We'll definitely reassess at the end of 4 cycles. The other question I would like to ask, Professor, is we sometimes go on at the end of 4 cycles. We would like to operate on these patients as quickly as possible because we are worried about the liver toxicity. How far away can we really wait before we operate, especially these liver mets? We are concerned that when we use oxaliplatin or irinotecan, we operate a little too late and they have some liver toxicity.
Well, I think there's some data coming from the Liver Met Survey registry, which is led by René Adam, and he clearly was able to show that 8 cycles of chemotherapy, everything is okay. If you go on with up to 10 or more, then all of a sudden the perioperative morbidity goes up. So I would say 2 months, which are 4 cycles, maybe 3 months, which are 6 cycles. And after that we go into surgery. But of course, we also have those patients that were treated in secondary cancer centers, then came to our center, and then of course, well, he's on treatment for a long time. If it's from a technical point of view easy, we won't undergo resection, but these are resection with a higher complication rate. So for us, it is usually 4 to 6 cycles of chemotherapy, 2 to 3 months before we send them to surgery.
So thank you. I think let's move on to the next slide, please, if there's any, because we have 2-3 more points to sort of cover. I think we already covered this issue of goal. And so now the question is on the maintenance. So I think Dr. Sebastian showed us data on cetuximab alone or in combination with 5 or fluoropyrimidine. So anybody wants to make a comment? Dr. Das, in a patient who is having either a stable disease or responding at the end of 4 to 6 cycles, would you give them a holiday, or would you, give them maintenance with cetuximab?
No, sir, I will continue the maintenance with cetuximab.
So as a single agent or with a drug like capecitabine?
With a capecitabine, sir. Capecitabine plus cetuximab.
So that's your standard practice, right?
Yes.
Okay, Dr. Parthasarathi? Is there, Dr. Parthasarathi? Or Sachin?
Yeah.
You worried about the side effects? Dr. Parthasarathi, yeah.
Yes, I use 5FU with cetuximab. The only problem is the skin toxicity of cetuximab in maintenance. So most of the people who have got initial skin toxicity will not be wanting to go for a very long innings with cetuximab. So in those cases, if they are unwilling, I'll give, I think 5FU or capecitabine alone.
Okay. Dr. Sachin?
Sir, I usually would prefer continuing cetuximab and adding capecitabine. That's an easier approach rather than maintaining central lines and repeated, longer hospitalizations.
So Krishna, are you okay with this? The data which we have in terms of survival and efficacy?
Yes, sir. I think most of us would continue cetuximab with the capecitabine because I think most of us would start with Folfox, so we would stop oxaliplatin, and 5-FU-leucovorin with its chemoport or PICC line usage. Generally, we tend to stop it and then change to capecitabine. I think most of us are comfortable with that, and I think reasonable data to suggest that we are reasonably okay with it.
Right. So can we move on to the next slide? I mean, anybody wants to comment on the maintenance? So because
I had a comment. So the data regarding maintenance with cetuximab is quite convincing. However, it's really a challenge in practice to continue maintenance with cetuximab. And I find that patients are quite reluctant to do it. And even after significant dose reductions, to continue 500 milligram per meter square every 2 weeks is extremely difficult. Unlike bevacizumab, where maintenance is usually a breeze, the skin toxicity is considerable, and I find a lot of challenging handling that.
Okay, so there are issues. Professor Sebastian, is that a concern, the toxicity of cetuximab, while continuing on maintenance?
Well, yes and no. So when we talk about, a patient that has nicely responded for like 6 months, then you switch to cetuximab maybe for another 3 months. And then I would usually go to an on-off regimen. If it's still stable, if it still has responded well after 6 months of treatment, I usually try to talk them into treatment holidays. And then, of course, because if you really go on with anti-EGFR for like a year or beyond, you get skin toxicity, also those nail toxicity, which are just ugly to treat. So I rather go to drug holidays for like 2 months, saying, okay, probably your tumor will return, but we have a very active treatment strategy on hand, so we will restart this. And most of the patients really like this idea to be off the hook for a certain amount of time and to, you know, go on holidays, whatever, before I restart chemotherapy. But I always tell them that most probably the tumor will have returned in 2 months. That's
Right.
just the truth.
Right. So Dr. Amit, are you here?
Yes, sir.
Yeah. Amit, I think Dr. Sebastian showed that you give 4 to 6 cycles of, you know, chemo and say FOLFOX and cetuximab, and then you give some maintenance, and 4-6 months or few months down the line, when the tumor relapses, there was an issue of, you know, going back to the same protocol, you know, I mean, because you're on maintenance cetuximab. So my question is, would you, you know, reinforce chemo, or would you just switch the chemo and the target at the time of relapse, say at, you know, 15-16 months?
So this is so earlier what we used to do was straightforward, change the chemo, change the biological, and make it FOLFIRI-Bev and go ahead. We did FOLFOX and cetuximab and then had a period of where they were doing well. It's getting a little bit more complicated with the NGS testing, which we are integrating into the space, especially not for the second line, but post-second line, the whole re-challenge question, the cricket question, the Chronos question, which comes in. So doing a good NGS and proving that you don't have that mutation to re-challenge again. But yes, for second line, it's fair enough to just switch directly to FOLFIRI-Bev if we have been on FOLFOX cetuximab. Second line is not an issue, but I think post second line, third line, we can't do it directly without at least a blood NGS showing us what the mutation profile is.
All right. So you are, I think, Nilesh, I mean, would you like to switch to FOLFIRI-Bev if somebody has had, you know, a reasonable time with cetuximab and FOLFOX and followed by a maintenance cetuximab?
Yes, I think at the moment until recently, that is the practice I have been doing, switching both the primary chemotherapy doublet as well as the target therapy.
Right. So Dr. Sebastian, I mean, I think since you put this thing into, I mean, the whole slides, so what is that, you know, how do you decide between switching to FOLFIRI-Bev versus, you know, giving FOLFOX cetuximab?
Well, I think at this point, you are still in a treatment part where it is active. I mean, 2 months is clear. 4 months and 6 months, well, I would probably, depending on the patient, if he has really, if he has problems, if there's a recurrence, I would probably give him maintenance. If he is fine, I would probably, after 6 months, I would just stop treatment for 2 months and re-challenge. I don't see, so well, the need to really change the strategy at this point.
Okay, so I think you mentioned that especially if there's a drug holiday for a few months, well, then it does make a point to stick to the same protocol which you started with, rather than changing the entire protocol and the partner. Okay, fine. So can we go to the next slide? So that is bringing us towards the end. I think we've covered this these issues of using the EGFR in the first line and then subsequently going on to BEV. So I think the question is regarding the re-challenge. Next slide, please. I think we can skip a few of these slides. Next, go to the re-challenge. I think we have covered the maintenance. Yeah, next slide, please. Next. Yeah, so I think this, yeah, we go to the, this one. So, you know, these are the options which are then available for a patient who possibly, you know, has gone through FOLFOX and cetuximab and maybe, you know, FOLFIRI, and BEV. So, Sachin, I think everybody is talking about cricket study and the registry study. Are you routinely doing NGS for KRAS or NRAS for that matter to figure out whether to re-challenge your patient with EGFR cetuximab?
So we do an upfront NGS RAS testing, pan-RAS testing, and so far I have used, redone NGS, a comprehensive panel for few patients. But that was for finding any additional things, additional targets and all.
Right.
So not for this purpose. So this is something recent which, I need to look into and incorporate. And otherwise, the practice has been giving, let's say, doublet with anti-EGFR, followed by doublet with change to FOLFIRI with bevacizumab, again come to anti-EGFR. I would like to actually know that how many patients who were initially wild type change into mutant, after this testing in this particular study.
Right. So I think the theoretically and even practically, what is happening is that the patients who are on a doublet and cetuximab, who were initially KRAS wild type, over a period of time, stop responding to the doublet and cetuximab because they turn KRAS mutant, and that is when we change to FOLFIRI BEV, and with the introduction of that alternative combination, the clone of KRAS, which was responsible for resistance to cetuximab, will go down, and then that patient becomes eligible for a rechallenge with cetuximab. So, Professor Sebastian, what percentage of patients will demonstrate KRAS mutations while being treated with cetuximab and FOLFOX?
Well, I mean, when we look into the data we have produced with FIRE4, it was 1 out of 5, so 19.5% of patients that were treated with FOLFIRI cetuximab until progression had an RAS mutation in the liquid biopsy at the end of anti-EGFR treatment. Well, of course, we know that those numbers go back the moment you stop anti-EGFR treatment. So you probably end up by maybe 5%, maybe 10%, we don't know, somewhere in between when we look into the data we have so far, that are still RAS mutant at the time of rechallenge after an anti-EGFR free interval of 3 to 4 months. Okay. So probably if you do a liquid biopsy, 1 out of 10 will show up with a RAS mutation at the time you want to rechallenge him. I usually have to say in this, if the patient is in a good performance status and no toxicity, I would probably go to irinotecan cetuximab, maybe also the reuse of FOLFIRI cetuximab, really depending on if there's hematotoxicity, etc. But if he has been on a very long first-line treatment and then a second-line treatment, usually we have problems with hematotoxicity. So sometimes I use cetuximab single agent if he still wants anti-EGFR, because if you're on treatment for 1.5 years, usually they say, okay, I had enough of this drug, it's okay. So it really depends on the personal opinion of the patient. The best data we have so far, of course, is the Sunlight study with TAS-102 plus bevacizumab. I think that's clear in this setting. Right. Because, and I would regorafenib and now also fruquintinib would be more like 4th line treatment at this point, just by the amount of data. I think rechallenge needs to show in a randomized trial superiority, and then I think we will talk about the reuse. And of course, at those times, I usually try to rebiopsy the patient or do a liquid biopsy. But in this case, I would also be very interested in the HER2 status at the beginning of 3rd line.
Right. So I think, so Amit, I mean, when you're looking at the 3rd line, are you looking at a rechallenge or looking at TAS-102 BEV, regorafenib? So, I mean, we do have patients who reach this far. So what are your thoughts? I mean, any comments?
Yeah. So So I think rather than re-challenge, we have been very happy with this TAS 102 with BEV data, and it's been really well in clinical practice. So for us, a go-to regime becomes TAS 102 with BEV. Yes, patients on progression, we do go to regorafenib, but post-progression on everything, we have actually looked at re-challenge, and we have done blood NGSs trying to see what you develop. The Chronos study actually showed very clearly that if patients just before third line, when you did it, 30% of patients developed a RAS mutation. So those 30% you don't have to treat with an anti-EGFR. The remaining 70 you could still give an anti-EGFR. And I think, sir, we have seen in our patients also that in the liquid NGSs, those who have picked up, quite a few of them have picked up a RAS mutation, showing that anti-EGFR re-challenge is not good for them.
Right. So I think ideally, yes, we should do the NGS in the blood, or if possible, as Professor was saying, maybe I think this is an era of NGS to identify more mutations, to look at any kind of targetable or actionable mutation. Nilesh, blood NGS for cricket study or for identifying, more mutations?
So blood or tissue NGS for identifying most mutations, yes, is something I do routinely, but not for specifically looking for the RAS status. I've not been doing that in practice.
So do you believe in re-challenge? So then, when you're not doing, so after a patient has failed FOLFIRI-BEV, so are you okay for re-challenge or TAS 102?
Either way, sir. There are some patients who will be re-challenged, and the others will receive TAS 102 with bevacizumab.
Dr. Das?
Sir, I would be comfortable with the TAS 102 plus bevacizumab because we don't have authentic data on the NGS profile, because in India, most of the NGS profile which we do are not adequately calibrated and adequately validated. So doing the NGS and proving that the patient don't have the RAS mutation, a blood-based NGS, and proving that patient don't have the RAS mutation and re-challenging it will be a difficult thing. And I would go by the data of TAS 102 plus bevacizumab rather than re-challenging.
I think in today's date and day, the availability of liquid NGS is quite free in the sense that it's readily available.
Yes, sir, I agree, sir, that it is free, but most of the investigation means NGS which we do in India, most of the investigations are not adequately validated.
Well, I think
maybe
some labs, good labs, have come of age now, and they are not only offering you 50 gene panels, but also 117 and 300 plus gene panels, which are quite reliable, like the Foundation. So yes, I think these labs are coming in. I agree with you that this is the beginning of the liquid NGS data, but I think the data is very promising from some of these labs.
Yes, sir. The data is promising, but we have to wait till.
Right. So, Dr. Parthasarathi?
I've been re-challenging cetuximab with good results of late, especially those who have got initial response to anti-EGFR antibodies. And if you have got something used in between, like BEV as second line, then those kind of patients respond very well. At least a good PFS will be obtained.
Absolutely, I agree, because TAS 102 has come, recently, and in the last several years, I think the re-challenge was the norm. Dr. Krishna?
Very few of my patients would go with third line, sir. Very, very few. And most of the time, re-challenge is with TAS 102.
Okay, so now you're using TAS 102. Okay, Sachin, or anybody else wants to comment before we move on to the last part of the discussion? Okay, Professor Sebastian?
Well, liquid biopsy is still, well, we are using it, especially within clinical trials. But whether we can really, the problem is still also for me, the validation. What kind of tests are we doing? Are we looking into a broad spectrum of RAS mutations? or are we just looking for one specific RAS mutation? So, sensitivity is different. And I think then is still the need of some more validation study. There's room for validation studies there. Also cutoff definitions. I just reviewed a paper where they looked into the variant allele frequency of RAS mutations in liquid biopsy to find a cutoff, a reasonable cutoff for those subclonal.
Would you do ddPCR or would you go for NGS?
Well, I mean, when I want to look for minimal residual disease, for example, in the adjuvant or the post secondary resectant area, I would rather go to digital droplet PCR. If I want to find other targetable actionable genetic alterations, I usually go to either FMI liquid or Guardant liquid, which is commercially available in Germany. I know the sensitivity is less, but I have more genes that are looked at.
Okay. So let's.
Can I ask a question?
Yeah, please.
So do you really believe in this concept of neo-RAS wild type? You have a KRAS clone at presentation and you are losing it. We saw the Godzilla Japanese study. They've made it so emphatic, but do you really believe it happens?
Yes, it happens.
Oh, amazing.
I mean, we had followed several cases. And first of all, I think it is clear that also within the RAS, if you look into RAS mutant primaries, we know, and there's a big data set with almost 2,780 patients where they looked into primary and metastasis, and they were able to show that 10.8% of the KRAS exon 2 mutant primaries are RAS wild type in the metastatic. Okay, so that's a problem. And but yes, you can use the RAS mutant clone during chemotherapy. It happens in probably something around 7, maybe 8% of the cases, which is quite interesting. Also in liquid biopsy, you see this phenomenon, of course, but I usually always rebiopsy those patients. I had published several patients where we really rebiopsied and we're also able to confirm that the metastasis that occurred was RAS wild type. And we treated them with anti-EGFR very effectively.
Oh, great. Good. So we look for this more now.
Great.
Okay.
Okay. So I think no discussion today is complete without discussing the immune checkpoint inhibitors. So I think, Professor, so you're looking for MSI and HER2 for all your metastatic colorectal cancers?
So HER2, yes, for all metastatic, MSI high for all patients, independently on the stage. So we do usually immunohistochemistry, and we do it from stage 2 up to stage 4 for all patients. I mean, there are different implications for this neoadjuvant treatment, etc. So yeah.
Right. So and if you MSI, if you get on the immunohistochemistry, do you confirm it with some PCR or maybe NGS, or you rely on the IHC?
Yeah, for colorectal, I usually rely on the immunohistochemistry. It's different in other GI tumors, also in other tumors like prostate cancer, which we know very well. But for colorectal, I think it's okay. So immunohistochemistry is fine, it's good enough. You're losing maybe 0.5% of your patients that may be treated with immune checkpoint otherwise. For younger patients, younger than 45, I usually do the genetic testing.
Right. So maybe you look for BRAF or you go for the germline.
We're looking for the germline.
Germline, right. Great. So I think Dr. Amit did show the slides on Pembro and the new data on Nivo-Ipi. So the current treatment would be the combination. Professor Sebastian?
Pardon?
The current treatment for MSI high metastatic CRC would be Nivo-Ipi?
in an ideal world, yes, but reimbursement in Germany, if you haven't had any kind of systemic treatment before, would be pembrolizumab, single agent. But I think that'll change in the next years as soon as we have the data of the HHW study available. If it's possible, if you got some kind of adjuvant treatment before, I would rather go to nivo-ipi. The combination is more active in my view.
Anybody has an experience with metastatic CRC first line ICI, immune checkpoint inhibition? Please.
Pembro, sir. Pembro we are using. We have patients doing well on Pembro first line, but we are very intrigued by the ipi-nivo data. So we have seen that crossover kind of curve. We have seen experienced it in our practice. There have been a few patients who did not respond at all to immuno, and that kind of always baffles us. What is that mechanism, of course, is causing that? So when you see the ipi-nivo data now, there's no crossover, there's nice separation, and there's really wide separation. So we are now thinking that should be the next ipi-nivo, maybe our way the next step forward.
Right. So, Professor, for the HER2 therapy, it's only in the second or third line, right?
So far, yes. I mean, the Mountaineer study is open at my site. So that's also one of the reasons why we do the HER2 always for all patients, because we have the possibility to put them on a trial with tucatinib plus trastuzumab, which is ongoing with 600 patients. It will take some time to have HER2 positive patients randomized in this setting. So I think it's an interesting option. So I'm happy that finally one of the pharmaceutical companies try to get a randomized phase 3 data on this issue, because as you had said before, with trastuzumab tucatinib, which the Hercules study, which we have seen, it's I think 15 years old by now, and then with all the positive data on trastuzumab tucatinib, but also of course on trastuzumab deruxtecan. I think it's a very interesting target, and we need to randomize data to really get to understand the true efficacy of this targeted therapy.
Okay, so before we close, your final word on the very recent data from ASCO and from the GI for MSS patients, the BOT and the BAL study from So are you excited on the metastatic or I think they're even looking at the neoadjuvant data for patients who are MSS, and they're using this combination of immune checkpoint and
I know.
Yeah.
Well, first of all, I have my own experience. I put one of my patients, which was later line metastatic colorectal cancer without any active liver metastasis on nivo-ipi, and it worked. Okay. I don't know if the non-active liver metastasis is really the clue. It's easy, it's clinically easy, so it's like left versus right, everybody can apply it right on without a complicated, maybe expensive testing, which would be the immunoscore that you, of course, which is, well, kind of available, but not really available right now, which has also shown interesting data in the AZETO-TRIBE study. So I'm not sure yet. There's not enough understanding. It's probably an immunological crosstalk between liver fibroblasts and the immune system, which obviously is inhibiting the PD-L1, the ICI efficacy. But as I said, I think the data is good. BAT-BOL is quite more toxic than nivo-ipi. This is something that needs to be said here. But I think it's the next step that needs to be explored. I'm very excited about this data. And as I said, I had a patient that I put on nivo-ipi, and it worked beautiful.
Yeah, so even there's data for nivo-regorafenib, and it does, and I think the difference is that patients perhaps who have liver disease, they don't tend to do that good than as compared to patients who have extrahepatic disease. So I think, yeah, right, Professor?
Absolutely, totally agree.
Yeah, so I think these are really amazing times for all of us and all our patients. And before we make the concluding remarks, anybody has any question or wants to make a comment, whether it's Krishna, Nilesh, or Dr. Das, please feel free. I think we have run over time. Any comments from any of the faculty?
Last question, sir. Transmet study, opinion?
So we looked at our own trial data, which is consisting of around about 2,000 patients so far. Within this, 5% of our patients would qualify for the Transmit trial. Looking into Germany, this would mean we would have additional 1,500 liver transplantations in Germany per year. The total number of transplantation in Germany today is like 750 livers per year. So this is not feasible for us. I think it's an interesting approach we have to develop, and we have to develop a better way to do liver transplantation from a living donor. I think that's something that needs to be explored more. And I'm not sure if 3 months of systemic treatment and stable after 3 months is good enough. I would rather go to 6 months, stable disease, nice response, strictly liver-only disease, where I would think about it. So we're setting up a system also in Germany to have some patients really that some patients get this kind of opportunity. But as I said, I think it's right now with the numbers we have not feasible.
Great. So I think one needs to keep that in mind for a very, very select group of patients, as mentioned by Professor Sebastian. So I think Merck gave us this opportunity to get together and really figure out the way forward for patients with metastatic colorectal cancer, especially focusing on RAS wild type. I think so much new stuff is happening in terms of sequencing, in terms of immune checkpoint inhibitors, MSI, MSS, BRAF, HER2/neu, and so many other actionable mutations. So I think the whole game started with EGFR and KRAS, but now it is snowballed into a very, very complex story. But I think it is good to have that understanding because we can personalize the treatment for a given patient depending upon the results of these sequencing approaches and other immunohistochemistry tests. So with this, thanks to each one of you who have sort of contributed to this discussion. And thank you very much for being with us for this sparing the valuable time. Thank you, Professor, and thank you all the faculty members and all the delegates who attended the meeting. Thank you very much.
Thank you so much. Have a nice evening.
Thank you.
Thank you.